Good evening, everybody, and welcome to our cardiac lecture series in partnership with Eisenhower Health. I'm Bill Stark. I'm the president of the Mended Hearts of Coachella Valley, and we're part of a national organization for heart patients and their families. Last year, we partnered with Eisenhower on how to increase visibility and provide more educational opportunities relative to managing and treating heart disease. Tonight, we are excited to say that we have about 60 people registered here in person at Eisenhower and almost 75 on Zoom registered. That's a pretty awesome type thing. Give yourself a nice hand there. That's kind of cool. All right. Running the Zoom site over here in the corner is our primary working partner in this endeavor, Brett Klein. So give him a hand, please. For those folks on Zoom, if you have any questions for Dr. Logsdon, please enter them in the chat room. We will have roving mics here in the Annenberg Center for questions as well, and we'll alternate between Zoom and in-person questions. Atrial fibrillation is a popular subject and affects numerous patients. They're treated by cardiologists, electrophysiologists, MDs, and surgeons. Our Mended Hearts visitors in the hospital see many patients with this problem, either as their primary or secondary diagnosis. Over the years, we've had several lectures on the subject, but tonight we're so pleased to have Dr. Daniel Logsdon, cardiothoracic surgeon, talk about the surgeon's approach to help with AFib. Please welcome Dr. Logsdon. He's going to also tell you a little bit about his interesting background and how he came to Eisenhower here. So, Dr. Logsdon, thank you so much.
Thank you guys for having me here tonight. So it's nice to see you all. I recognize some faces, you know. I recognize some faces. Some may recognize me. I think I've operated on a few of you. It's good to see you're still here. So a little about me, as I didn't put a slide together for it. It was in my other presentation, but I grew up in Ohio. Pretty much spent my whole childhood there. I was born in Alaska, though, and then I ended up at Purdue doing chemical engineering for a few years there. I got my degree. More, you gotta be louder. Yeah, you happy there? Turn them up. Turn them up. I usually am told I talk too loud, so. But I guess you guys can self-adjust for that now, so we're good. So I went to Purdue for engineering. I did chemical engineering there. I ended up taking a job with ExxonMobil for a few years, trying to figure out what I wanted to do. Medicine was always kind of in the back of my mind, and so that's how I got into medicine. I ended up deciding to go back to med school at LSU in New Orleans. So I did med school there. I did heart surgery on a whim. It was just one of those rotations that you're like, well, I'll probably never do this again, so you should at least spend a few weeks to getting to see an open heart surgery. And then it just clicked. I had some really good mentors along the way that just kind of showed you the path, and they were really good about getting me involved and showing me the intricacies of it. And from an engineering standpoint, it's just a pump with some pipes and some fluid flow. So it's pretty simple to understand. And so for me, it was easy to break down. And then I ended up at USC for 7 years doing training, and then I've been here for 18 months, about 18 months or so. I got here August of 2021. So and that's been the journey here. We've grown the program a lot. There's a lot of things happening with Eisenhower, just with hearts in general, from the cardiology front, from the surgical front. We've just seen an increase in our population here. We've also seen an increase in our ability to handle complex cases and also treat things that were previously probably untreated, and AFib was one of those things. And that's why we're talking about it tonight, because about 30% of patients who have open heart surgery will develop AFib, typically in the hospital, maybe a little bit higher. And so if you've had heart surgery, you probably know about AFib. You've either had it or you know someone who's had it. So that's what we're going to talk about tonight. It's typically managed by a cardiologist or your primary care doctor, but surgeons, we treat it too. And we actually here at Eisenhower have an AFib team that we've developed over the last year, just because of the growing need for it. So here's a little spin off of how surgeons think about it. We like fancy videos. I hope these play. So let's start with what a normal heart looks like. It's here on the right. This patient has had a surgical ablation. They came in an AFib. This is what it should look like. So you see the first portion there, it kind of looks like it's in sinus. That's the atrium that's there beating. That's here. I don't know if you can see my pointer, but that's the atrium beating there. And so that's sinus. So it's lub dub, lub dub, lub dub. So hopefully that comes through okay for you guys. And you have the body heart. Our technical team is on it. This should be fine. He's getting one. Here we go. Yeah. Correct. So there's correct. So a little bit about anatomy. So your heart has typically 4 chambers. 2 of them are atrium and 2 of them are ventricles. The atrium typically contract to fill your ventricle. Your ventricle is the pumping chamber. So it either pumps the blood to your lungs or it pumps the blood to your body. And when you're in AFib, you're not filling your pumping chamber very well. And so what you see here on this video on the left, we'll play it again. I hope everybody can see it. This is the atrium here. You see it fibrillating, right? That's it. That's fibrillation. This is the surgical view of AFib. See, I understand it now. You talk to a cardiologist, they're very specific. I'm like, this is what AFib looks like. This is what it's supposed to look like. Boom, boom. You see the difference? What's enlarged here? Well, this is actually an aneurysm case here, but he was in AFib, so we treated his AFib. So this atrium is a little large, but it's not the largest one we've seen. The heart functions normal. Your ventricle is down here. So sometimes just seeing this explains it. And sometimes when we talk to people with AFib, or if you had it, you may feel that. You may feel this type of fluttering a little bit or this fibrillating. You don't know what it is, but you get a little uneasiness, a little feeling there. This is what you're feeling. Your body's recognizing that. Okay, well, here we go. Left heart, AFib, right heart, sinus. I think the videos explain a lot of what it is. So how many people have AFib? It's a growing problem. We know that. We see it. We see it in our communities. About 8 million patients in the US have AFib. It's huge. So it's in a regular heartbeat, right, or arrhythmia. And like I said, worldwide, it's 33 million. So 8 million here and 33 million worldwide. And that's just the ones we know. Right? A lot of this goes undiagnosed. And why is it such a big issue? Why are we talking about it, right? You got a 5 times higher risk of a stroke when you're in AFib. You got greater than a 5 times risk of going into heart failure. And that's the long-term consequences. These patients end up in heart failure. And if you look at all these patients together, you got a 46% greater risk of all-cause mortality, meaning any cause of death, but those patients with the AFib have a 46% greater increase. And those that have AFib typically have other major cardiac complications, and that can either be valvular heart disease, heart failure, or it can also be coronary disease. So every year, like we said, there's about 8 million now, and every year we're adding about 1.2 million to that in the US. So how does it impact your life if you have AFib? Who here has AFib? Just put your hand up. Yeah. Okay, so who has had treatment, surgical treatment or ablation for their AFib? Okay, so we had about 30 hands go up and about 4 came up that said they've been treated for it, right? So I would say it's untreated disease, even just in this population here. So typically, if you look at 15 months in your life, because I guess a year was not enough to get the data they wanted, so they went 15 months to make it complicated. You average 3 emergency department visits in those 15 months. So every 5 months you're coming in, and we see it here all the time. If you have AFib, have you been to the hospital in the last year? Yes. Yes. Okay. A lot of hands shaking. Yes. Okay. We probably need that. You have about 12 outpatient hospital visits. So meaning you're going to see your cardiologist, your primary care, you're going to call in, and you're going to ask us questions about your AFib to manage it. Right. And then if we poll those people that have AFib, about 47% of them have a reduction in their quality of life. And the whole thing we're doing here is trying to get better quality of life. You know, we just want to enjoy the things we enjoy and get back to doing them. And AFib prevents a lot of people from doing that. Yet in the medical community, sometimes we don't ignore it, but because the problems it causes are farther down in the road, and it's not something immediately that we think we need to treat, we let it persist. But what we forget is that it does affect their quality of life. And then they do have about 67 physician encounters. Again, that's the phone calls, the MyChart messages that I get that we message and respond back to. And that's a lot. That's one every 5 days or so. Every 6 days, you're messaging about something going on. And we see that here in real-time data. So if we take everything that's going to kill you, cancer, all that, let's just take a look at where AFib falls in. I don't see coronary disease on there. I don't see valvular disease, but I do see AFib. And these are Medicare patients over the age of 65 within 5 years of AFib diagnosis. So have a 51% survival rate. So yeah, we don't necessarily think about it that way because again, we don't make a big deal out of it when you're in AFib. We put you on some anticoagulants and we'll kind of talk through that. But it's a big deal if you look at all-cause mortality here. So that's where AFib fits in when it comes to different types of cancer. So I would say it's deadlier than lymphoma, colon cancer, chronic leukemia, melanoma, breast cancer, and prostate. So what about the economic burden, right? I mean, this country is going through some changes in policies. Whether you stand on one side of the fence or the other, I mean, it's happening, and there's reasons why. By 2030, there'll be about 12 million people in the U.S. that have AFib, right? It leads to over almost 500,000 hospitalizations per year, where it's just the diagnosis. This isn't people that come in and we find out that you have AFib. These are people that come in because of their AFib, right? And it costs about an extra almost $9,000 per patient when you have AFib per year to treat. I get it. It fills up our emergency departments with over 500,000 visits. And then of those patients, about 65% end up getting admitted. So talk about a disruption to your life, having to come to the hospital, find out, wait 12 hours in the ER, and then find out you have to get admitted and stay a couple of days. I mean, it just completely disrupts your life. And it's costing us about $26 billion per year. And it's, again, it's not so much about the money or the time. It's about the quality of life that you're losing because of what it takes to treat, or just because of the AFib and you coming in. And so the question is like, what are we doing about this? It's a very much an untalked about problem that in this room, like I said, almost 60% of the people here have AFib. Okay, so patient selection, right? So what are the risk factors? It's kind of like, what's the risk factor for cancer? It's like, well, I'm breathing oxygen today, but AFib does have some common risk factors. It can be other heart disease. So you see over here, valvular heart disease is one. Sleep apnea is another one that we see a lot of that we don't talk about. So people that sleep with CPAP machines, you're treating your sleep apnea. It's actually reducing your incidence of AFib. Obesity, yes, obesity causes just about every disease that we talk about. We talked about valvular heart disease. I think the other one we don't talk about enough is probably alcohol consumption. Alcohol is oftentimes the primary trigger for a lot of people going into AFib. And so it's one of the things we talk about in the treatment course of AFib is, all right, we're going to treat you medically. We're going to talk about surgical treatments and ablation therapies, but we also need to talk about lifestyle modifications. Because again, the question is the alcohol you're drinking improving your life by 47% such that the quality of life data that we're collecting, is it worth it? And that's really what it comes down to. And oftentimes, it's not so much abstaining as it is just limiting the consumption in a day. And it's very easy to go out and have 3 drinks at a dinner. And next thing you know, I'll get somebody in my office who's in AFib and they're like, yeah, I didn't know it would set off my AFib, and it does. So that's the one that we don't talk about a lot because it's very socially acceptable, but for AFib it is a very high incidence of. So when we look at AFib patients, there's all different types. There's something we call paroxysmal. I know it's a tough word, but this is it, paroxysmal. And just to break it down, right, it's a fancy way for doctors to talk, but it just means it happens occasionally and can last up to 7 days. So if you look at all those AFib patients, 30% of them have paroxysmal. So it kind of comes and goes, but doesn't ever last more than 7 days. Then you get this middle category. It's like a middle child. It oftentimes gets overlooked. It's persistent, about 25% of the patients there. And it lasts somewhere between 7 days and as long as 1 year when you have your AFib. And then there's this long-standing persistent group, which if you're here and it's been over a year, you fall into that category. These are the people that are at risk for the biggest loss of quality of life, progressing into heart failure and other comorbidities that comes with having AFib. And these are the people that last longer than 1 year. And oftentimes we rate control you. We give you medication to slow down the response of the AFib, but you're still in AFib. So the risk factors are still there. So, all right. So how does AFib begin, right? This is very interesting. So if we look at AFib, and the remodeling that happens with it. So your heart starts to change when you go into AFib. It starts to weaken, right? Rather than contracting like we saw in this video, where it was contracting, it just kind of fibrillates. So it weakens over time, and that weakening, as simply as I can break it down, it changes the contents of the heart muscle. And so it begins over time to oftentimes dilate. And so what you see here is kind of the time course of progression. So if you look, here's that word again, paroxysmal, right? So you get these patients that are in paroxysmal, right? And so it shows it maybe 5 years, 10 years, and then somewhere in here, it switches over to persistent. And then sometimes it gets into what they used to call permanent is now longstanding persistent AFib. But look at this, right? So there's two things on here. You see two lines, you see a red line, right? And that's the remodeling of the heart. That's the biggest problem. We don't know until very far down the line. Look how long you've had paroxysmal AFib, right? It comes and goes every so often. At 10 years, you start to see some significant remodeling, but look over the next 5 to 10 years after you hit that 10-year mark. It's very hyperbolic, the remodeling that happens and the speed at which it happens. And the same thing of the risk factors, right? So you see this risk factors here. Okay, yep. Kind of cruising along here. And then you start to go out 10 years and the risk factors start to increase pretty significantly. And so this is something that the medical community is beginning to address. We're beginning to offer more options, because as we follow these patients in our data sets, we say, like, what's happening to them? And we see over time they are progressing into heart failure. They're having these complications, but oftentimes it may take an entire career of a physician, right? How long are we practicing? 20, 30 years, right? Where your patient that you had 20 years ago is now just starting to see signs of it. But when we start to look at the data collectively over many, many years, we start to see that at, this 15 to 20 year mark, you really start to develop some problems. So here's another picture too, to kind of, I'm a big picture guy. The words don't mean as much, but if you can see anything here, you see that the heart begins to change size, right? So the atrium are these two chambers here, 1, 2, right? So this is the right atrium, this is the left atrium. Just look how they progress over time, right? And so on the left, you have no AFib, you have paroxysmal AFib, and then you have this long-standing persistent AFib. This is heart failure, right? This is going to affect your valve function. It's going to affect your ability to what we call cardiac output reserve, but your ability to exercise and be able to tolerate it for longer periods of time. And so these are the things we see in the heart. But again, remember the time course. It can be over a long period of time. So like I mentioned before, this long-standing persistent group is about 45% of our population. And that's who we're really going to talk about addressing today, because those patients are the ones that we've studied significantly. So if you have AFib, like some of you in the room, you may notice some things here. You may have shortness of breath. You might get dizzy. You may have some weakness, fatigue. Your blood pressure may be lowered. Again, that's all because your heart, your pumping chambers aren't being filled. It's a very simple thing. If you don't fill the pumping chamber, you can't generate a pressure. If you can't generate a pressure, guess how you feel? Fatigue, weak, dizzy, and maybe short of breath. So it's all related to the inability to fill your pumping chambers. All right, it's a fancy slide. This is from a study that we won't dive into, but it really helps to look at the anatomy of the heart. So what you're seeing here is actually the back of the heart. So most of you will never, well, you saw the front of the heart. You'll never really see the back of the heart. And the back of the heart is where all the action happens for most of AFib patients. It actually happens around the veins from your lungs. So your lungs both have a set of veins that drain back into the heart. And that's these veins. You can kind of see them here, the LSPV, the LIPV, and the similar on the right. So the main source of initial AFib comes from around those veins. And what happens is that they begin to get distended, they have a stressor on them, and they begin to act on their own. Because the heart, what's interesting about the heart is it has a pacemaker, right? You can take the heart out of an individual and you can sew it into somebody new in a heart transplant. And once you put blood back into the heart, it knows exactly what to do. It's no longer connected to the brain. It's no longer connected to any part of that body, and it knows what to do. That's the amazing thing about the heart. It's a standalone organ that can function by itself. Well, in AFib, you've disrupted the ability for it to have the signals to tell it to beat normally. And so what happens is when those signals, that's what you're seeing over here in B, you're starting to see these abnormal signals forming. And when they form, everybody's like, hey, follow me, I'm the leader now. I'm the leader. I'm the leader. And so you get mixed signal, right? And that's what you're seeing when the heart is fibrillating. You see in all these little guys, they all want to be the boss. They all want to fire. They all want to be in charge. And who's usually in charge is the sinus node. The sinus node usually says, all right, everybody get in line and fire. Boom, boom, boom. But in AFib, it's nobody's following anybody. And so what we try to do is we try to eliminate some of these signals. And so these are all the mixed signals you see over here, right? And so what we do in treating is we try to eliminate all of these signals. So what are my treatment options for AFib? Lifestyle changes, we address that. Better manage your diabetes, watching the alcohol consumption, staying active, losing weight, all the things you hear all of us talk about commonly, right? And then there's the other side of it. So there's medication therapy. So some people might be on a beta blocker. Some people might be on amiodarone. Some people might be on diltiazem. I bet if I asked you who's on it, some of you in the room are on some of those medications. Some might be on flecainide. Some might be on sotalol, right? There's an armorum of medications that we use to try to, one, can put you back to sinus rhythm, and two, control the response. So help to slow your heart rate down when it speeds up in AFib. So that's the medical side of it, or at least the rhythm management of the medical side. The other side of it is you're probably on anticoagulation. I'm sure if I asked you, a bunch of you are on a bunch of blood thinners here, and we'll talk about that in a minute. And so that's the medical side. And then we progress into kind of the treatment side. It usually starts with a cardioversion. How many people here have been cardioverted or shocked? Yeah, okay, yeah, so about 6-7% of them. So it's not the most enjoyable experience to have electricity shock through, but it's kind of like calling IT support. What do they tell you? They're like, have you tried restarting the computer yet? Okay, same thing. Right? So restart the computer. So they just reboot it and hopefully it comes back on right. So that's effectively what a cardioversion is. And then there's more treatment after that include ablation, which you see down here. And that's kind of what we're going to talk about today. Some of the advances in ablation that have been making significant differences in some of these difficult patients to treat. So when we talk about intervention and things for treatment of your AFib, one of the first stops is with your cardiologist, your electrophysiologist. We have a great team of electrophysiologists here, Dr. Feldman, Dr. Rubin, and Dr. Diamantacos that manage your AFib, and they typically do it through ablation. And so the easiest way to simplify this is that, you know, I told you that the sinus node is the leader of the heart. It tells everybody when to fire. Well, when you get these mixed signals coming in, everyone's trying to take charge and the sinus node can't take charge. And so what we try to do is we try to block out all those signals. So if you're an electrician, it's like creating a little bit of a short circuitry, right? So we're blocking all of those things out. So there's only one pathway for the electricity in the heart to go, and it's the way it was meant to go. And so we help the sinus node out by blocking out all those signals. And so a couple of ways we do that. We use techniques. We can use like radio frequency ablation. So we go around and we treat the left atrium. So if you remember some of those pictures I showed you before, these are the pulmonary veins here. I don't know if you can, yeah, you can see my pointer there. These are the pulmonary veins, right? So we direct most of our treatment here. So we can go in and directly treat around that. And our electrophysiologists do a very good job of doing that. We also are able to do what we call cryoballoons. So we use a balloon that we actually are able to pump some liquid into and cool off over time, and it actually cools, and that cooling actually helps to disrupt some of the electrical activity in the heart. And so there's multiple techniques that we're able to do initially to begin treating your AFib, and your cardiologist, your electrophysiologist will kind of talk to you about the timing on when these things happen. But these are things that we are looking at starting to do earlier and earlier in the treatment of AFib.
Where's the sinus node?
Right. So it actually sits, I'm going to go back a few so you can actually see it. So the question was, where's the sinus node? So the sinus node sits right here. So yeah, so it's it's myocardial cells that have, they have certain, on their cell structure, there's the ability for chemical electrical potential. So we're going to get a little specific for a second. So if if you need a sip of coffee, that's fine. But you know, your heart works through conduction potentials, like action potentials. So it has a signal, and there's a certain chemical gradient that develops up over time. And when it develops up enough, it sends an electrical signal. So the SA node has the ability to send that signal on its own. And once it sends that, it propagates all the way down. So the sinus node has an internal ticker that's doing all that stuff, but it's all based off of chemical potentials. But it typically sits right here. You never really see it. We just know where it is anatomically. And that's one of the most difficult things about treating AFib is you're like, well, where's the electrical conduction system? Well, we know where it lies from doing a lot of electrical studies in the heart, mapping the heart, but we can't see it. You can't visually see any of this. You just know anatomically where it's typically located in most hearts. And so again, that's why treating AFib requires a multidisciplinary team that can help find the electrical signals, right? Our EP cardiologists are very good at doing that. We map it from the outside of the heart as well, but it helps to tell us where those signals are coming from because you can't visually see it. So you're kind of almost hunting in the dark until you turn on the night vision goggles, which is our ability to look at the electrical activity. So yeah, that SA node sits right here. And so you see this conduction line over here. You see this is an ablation line. So what we've done is we've taken one aspect of that abnormal conduction that was over here, and we've blocked it. And so now we have the SA node, which is here, is able to conduct normally. Yeah, so ablation is a simple term meaning that it's you take the myocardial. So the question is, what is ablation? What does it mean? And so it's the ability of completing so we talk about terms of transmural. So we talk about going through the entire heart muscle. So it's the ability to complete a transmural lesion, and a lesion is the kind of like the development of scar tissue there. So if you had healthy electrical muscles signal there, it's the ability to block that. And so we do that through a couple of things. Like I said, we use radio frequency to kind of, it's not like burning, but it's kind of like burning that heart muscle and taking that signal away. And it ends up forming a little scar tissue there. So it's like forming little walls in the heart muscle. And so if you look at the heart muscle over time in pathology, and I didn't put those slides in here, you can see actual physical changes in the heart muscle that occur. So when we talk about treating AFib, we look at ablation, right? And so it's not always the best option long term. It works and it helps a lot of people, and it has very low risk because it's not open heart surgery to treat it. They're able to treat it through accessing one of the veins in your legs. I'm sure some of you in here have had ablations, and you can kind of testify to that. But if you look over time, and again, you're going to have to look at a lot of data, and I'm not going to get into a bunch of discussions about that because that's not the purpose here. But if you look at it over time, what you see, like even over a 12-month period of doing some simple ablation therapy on these long-standing persistent patients, that over time, right, the freedom from AFib with just one ablation in the setting of long-standing persistent is around 20%, right, at 6 years. So it falls off very, very quickly, even before the first year. So that's what these curves are showing is, year one is here. Blue line is one ablation. So you're ablating these people, and within a year, almost 40% of them are only free from it. That means 60% have reoccurred with AFib. Now, if you ablate them 2 times, you'll see here that you have a slightly higher rate, but over time, it's still very difficult to quote unquote cure AFib. And so that's one of the things that we're kind of changing the talk about is like, how do we reduce your symptoms from AFib? How do we keep you in AFib primarily majority of the time? But it's very difficult long-term to keep yourself up here. Now, there are people that make that where they have no more AFib after one ablation, but that is more of a unique experience than what we expect. And then again, if you look over here, we talked about it, single procedure success is around 43% when we go in with just one procedure. So the question is like, how can we combine what we do with our cardiology colleagues with what we're able to do surgically? And that's kind of where we're starting to advance. Again, this is some more data that just kind of shows that over time, primary endocardial ablations, although they're very effective, there has some limitations. And those are things that we're trying to address together here at Eisenhower. And so kind of just to conclude that before we get into the more of the surgical part, I wanted to give you guys a history of AFib, kind of talk about how we typically treat it, because you may have your meetings and your appointments with your cardiologist to talk about that, which are extremely important. But I want to dive into the surgical parts next. But what you see is that when you talk about these patients that have had AFib for over a year, they have very high recurrence rates. There's risks of having complications with multiple endocardial ablations. It's not without risk. And what we see over time is that the effectiveness is just not there. And so that's kind of how we began this program here at Eisenhower. And so again, getting back to the progression of AFib, we're going to address these long-standing persistent patients in surgical ablation. So what we've coined the term kind of hybrid atrial fibrillation therapy. And what that means is it's a mixture of the best of endocardial ablation, the things that are very difficult for surgeons to treat. Our cardiologists are really, really good at it. And the part that's challenging for the cardiologists to treat, they're capable of it, but challenging to do, we're able to do surgically with what we would consider a minimally invasive approach to it. And so this is where the term hybrid, because now you're joining the best of both teams to give you an effective therapy. And so the history of surgical AFib treatment actually came with a guy named James Cox. He was out of Washington University in St. Louis. Interesting guy. So like he started diving into this in like the 1980s, even before that in the 70s. And we used to do it all with cutting and sewing. So we would cut the whole heart out. We'd cut all these lines, and those were the ablation lines. We didn't have fancy technology to do it. You know, they would have to cut every little line that you see here, all these blue lines here. They would have to physically cut that and hand sew it back together. Dear God. So we don't do that anymore, but it was very effective because it created an ablation line. And that's effectively what we're doing with ablation is we're dividing that muscle and separating it from the other piece. And so it still remains the gold standard for treatment because it is a complete isolation therapy for the heart. The issue is a lot of times it involves open heart surgery. So sometimes we do it when we have to open your heart for something else. We'll go ahead and do a full maze procedure, but to open your chest and put you on a heart-lung machine for that, the risk there is probably not worth it. And so we don't usually complete the maze procedure unless we're doing something else. And so what we've been doing over time is how do we mimic the results of the Cox maze procedure, which we know works really well? How do we mimic that with reducing the risks of doing it? And that's where the hybrid ablation comes in. So what is the hybrid ablation technique we're talking about? And so we call it the convergent procedure. And so it combines, like I said, the endocardial ablations with the epicardial ablation here. And so what you're seeing here on the left, this is actually the back of the heart. So this is a very difficult part of the heart for the cardiologist to treat. This is what I was showing you. Your pulmonary veins are here and here. Surgically, we approach this with a very small incision below your breastbone. And then we're able to use a device here. If you come to my clinic, I'll show it to you. I have one there. This is uses radio frequency ablation, and it ablates the back of the heart, this posterior wall. It's very challenging to treat. And then after you have that portion of the treatment done, our electrophysiologists who treat our pulmonary veins very, very well are going to come in and they're going to treat the veins where I have difficulty getting in contact with. And so this combination of these two therapies has proved very, very effective. And so here's a few more pictures of that therapy. You can see this here is your breastbone. We access with a small, probably like a 3 centimeter, 4 centimeter incision here, and we're able to actually get right behind the heart. And that's what this is showing you here. That incision sits right here, and we're able to come right up underneath and do that. And the patients that typically have this procedure usually stay in the hospital about 1 night. 1 to 2 nights is what they stay. And then they'll follow up with our cardiologist in about 6 weeks, 4 to 6 weeks to get the other portion of that treatment. Here's a little picture and a video that hopefully will play here. This is the back of the heart. Right? We keep talking about this left atrium. Well, here it is. And here's the scar tissue afterwards. So this is one of the cases we did this year. It's going to be like turbulence on a plane ride. So if you get motion sick, don't watch, but you'll start to see it. This tissue here in the pink, this is what the back of the heart tissue typically looks like when we start. When you start to see it darkened over here like this, looks like a charbroiled steak, that's how ablation should look when we're done epicardially. And so you're going to see that we're able to treat the whole back of the heart here. And the heart's beating the whole time we're doing this. Oh, there's a pulmonary vein there. That's right there. There's a pulmonary vein over here. Right there. And then we're coming back around. And so this technique has been around, I would say, for probably over 5 years, but it has some recent FDA approval that's allowed us to begin advancing offering this to more patients. And as more data comes out, we begin to see the effectiveness of it. And so what we do when we do this treatment, I think this is the coolest part too, because I love pictures. I mean, I take pictures of everything, is that on the left here, you see AFib. This is what AFib looks like with electrical activity. So we're measuring voltage on the back of the heart. And so we use a little catheter to measure that. But you can see, I mean, again, pictures speak 1,000 words, right? If I did anything in this talk and I just showed you the first videos of the hearts beating like this, and then I said, hey, this heart on the left has AFib and this one on the right is after ablation, you'd be like, oh, yeah, it looks right. Yeah, it looks good. So what you want is you want it to look gray. That means that electrical activity that was causing the problem, all those little guys that thought they were the boss, yeah, they all got fired. They're all gone. So that's what happened here. And so every one of these hearts, we're very meticulous about doing this. We map the AFib, we find where it comes from, because again, visually we can't see it. But on here, I can see it. This is all AFib. This looks like, like Hurricane Katrina coming through. This is what somebody looks like when they're in AFib. And our job is to go in and make it look like this when we're done. So the other part of treatment that we want to talk about is your left atrial appendage. Some of you may have, anybody have a Watchman device? A few people with Watchman devices. So we'll talk about the left atrial appendage. So it's important because who here takes a blood thinner? Yeah, raise them up. Yeah, it's a lot. So it's either, I think Eliquis is probably the primary one. That's what I've been seeing more and more. People take Xarelto, people take Coumadin, people take Pradaxa. Those are kind of the main 4 that we use to treat your blood. And the reason we thin your blood is because if we remember back at the beginning, I know it was a while ago, he's still talking, but AFib has a 5 times increased risk of stroke rate, right? Well, being on a blood thinner helps to reduce that significantly, but it comes at a slight cost. It comes at the risk of bleeding, comes at the risk of being easily bruised, and some people don't tolerate it. So the reason you're on a blood thinner is because of your left atrial appendage. So it's a little part that sticks off the heart here. It looks like this, okay? It's big. It looks just like this. Here's an actual picture of one that we did, right? So this is it. That's what it looks like. And so when you're in AFib, remember what that heart looked like, right? It's fibrillating. It's not actually contracting. And so if you were to cut yourself and the blood was going to sit there and you weren't on a blood thinner, what happens when the blood sits after you let it go? It clots. Yeah, it's not rocket science, right? You guys already know this. I don't even have to give this talk. So it clots, right? And you get these weird little finger-like lakes, right? You get these weird shaped things. And if it's not contracting and it's got this little thing here, I imagine blood would probably like to go in there and clot. Well, that's fine. Clots don't bother me. I actually like it after open heart surgery. I appreciate when you make clots because that means I don't have to stand there and dry it up longer. I can keep going on after the surgery. But clots in this setting are bad, right? So if we remember the left atrium, right? The blood from the left atrium goes into the left ventricle. The blood from the left ventricle goes out to the body, right? So you see this right here. I don't know if you can see it. This structure here, it's your aorta. The first 2 stops that blood takes after your aorta goes to your right brain and then goes to your left brain. So if you have a clot that dislodges from the atrium, especially this appendage, and it gets ejected from the heart, where do you think it's probably going to go? The brain, right? It's not. It's the first 2 stops that it goes, right? It's stop 1, stop 2. So that's why there's such a high stroke rate. So what do we do about that? Well, we know the significant portion of the stroke risk, almost all of it, comes from this appendage. It comes because of these little areas where blood sits. Because you're not going to have a massive clot, right? You're going to have these little ones that go up. And so what we do is we typically manage this. There's 2 ways we do it. This is the surgical approach, right? Because some of you have a Watchman. It goes from the inside and occludes the appendage. And then you have a surgical approach here, right? And this does involve surgery and involves us putting a small camera in here into your left chest. So we go by your left lung. We go in there and we open up your pericardium, and then we put a clip on. So what does that look like? Well, good thing I like to take videos. I think it's the millennial generation. We video everything. There's your appendage. That white thing there's a clip. That's me moving it in there. I just kind of milk it in, make sure all of it's in. We're looking at it under ultrasound as well, making sure it's all intact. And so we just access the heart from the left side here. We do our checks. Okay, make sure everything looks good. This takes us probably start to finish, maybe 20 minutes. And then what we do is this little clip, this little white thing here is the clip. We let it close. You see how it closed? Everybody see that? Oh, here, watch it again. Let's watch it again. Here we go. That's the atrium. That's the atrial appendage right there. That's what I'm touching. I'm making sure it's in this white clip. You see this little white thing? That's the clip. It's open right now. You see how it's open? Watch this white thing here in a second. It's closed now. They're touching. You see that? Let's do it again. That's about how quick it takes me too. Here we go. One more time. And here, wait a minute, wait for it. And your stroke risk is pretty much zero now. Okay, next patient. So that's what happens though, right? So we clip that. And the reason we do that is because it significantly reduces your stroke rate. And so this one, and this approach obviously involves surgery, but occasionally patients aren't candidates for Watchman devices. And so this is how we'll do it. We believe in this so much here that we've actually clipped probably 99% of all of our open heart surgery patients now when they have surgery with us, because who has had open heart surgery and has AFib on a blood thinner? A lot of questions, or a lot of you. Yes, Bill, I know you do. And so if your appendage was managed at that time, you probably don't need to be on a blood thinner. And so when you think about AFib and the incidence and the risks that it over a lifetime, putting a clip on somebody makes a lot of sense. And so surgically, we treat every single appendage now because we believe in it so much. If you didn't have it treated then, we're able to approach it like we do in this video here. Well, it occludes the left atrial appendage. So the question is, what does the clip do? So it prevents the blood flow from entering the left atrium, at least the atrial appendage here. So that's the appendage. It's full of blood now. You see how it's so, it just looks like it's full, right? It's filled. And so when we close this clip here, we eliminate the ability for blood to enter that appendage. And therefore, if blood can't enter in there, it will not clot because there's nothing in there to clot. And now it's flush with the rest of the atrium. And so everything that's in there, eventually this atrial appendage, it just kind of involutes. It just kind of falls in on itself. Yeah, question back there. Well, we need to talk to your cardiologist about that, figure out why. Yeah, everybody kind of manages it differently. You're in a changing paradigm. It's a very good question. The question is, if I've had my appendage managed and I'm still on a blood thinner, why? Well, we need to just talk to your practitioners and see their reasoning why. Sometimes they have some reasonable justification for it. Sometimes it's just about re-educating on some of the new data that's coming out. Yep. Another question in the back. Yep. Good question. So what's the purpose of the appendage? So what's interesting, most of us here will never have any benefit of our appendage. It does add some, the ability to fill your left ventricle when it's at maximal excursion. So think about Olympic athletes, right? They're winning things by 1/100th of a second. And so they need as much blood flow pumping into their left ventricle so they can pump it out to their muscles to go. Well, your left atrial appendage is that extra little storage capacity. I was telling my son the other day about like how I used to have a truck. One of my friends had a truck when I was a kid that had 2 gas tanks in it, right? So you could like flip one on and flip on the other. That's kind of it. It's kind of a little extra storage reservoir that when you need it at maximal excursion, it can help fill that left ventricle more. So that blood is very important. But eliminating it from the majority of us, because none of us are Olympic athletes, doesn't usually make any difference at all to our ability to exercise or our capacity. So, yeah, one more question. Yep.
The general question about the heart. You know, research shows, I guess, the brain, we can develop growth in the brain and it can become healthier the more we use it. Is there anything like that analogy to the heart?
100%. 100%. So the question is there, you know, as we continue to grow and I guess use our brain, use our brain, like we know there's some studies that show like, oh, your brain gets stronger, right? Do some crossword puzzles and you can maybe reduce some dementia, right? And so there may be some studies that show that for the brain. Well, for the heart, it's similar, like being in sinus rhythm means your heart's actually contracting. Contracting is like, hey, I'm going to the gym, I'm working out. Your heart's not getting floppy. You'll see over time when people are in AFib, the heart becomes very floppy. It loses its ability to contract. And it happens for a couple of reasons. One is the electrical signal is not there to tell the muscle to contract properly. 2, over time, it scars in and it begins to form fibrosis. And fibrosis is not muscle. Fibrosis will not contract. And so that atrium is just sitting there. So when you go back into sinus of rhythm, there's this process called remodeling that we see, and it takes years sometimes to do it, but over time, your heart will regenerate muscle, right? It will regenerate the ability to contract, right? Depending on where you're at in that spectrum. Now, there are going to be some hearts that have been in AFib for so long that they will probably never be able to regenerate their heart muscle. That's just the facts of the matter. So one of the things we are trying to address is, okay, let's catch our patients before they get to that point of quote unquote no return, right? And that may be 15 years, that may be 20 years, that may be 30 years, you know. We don't really know until we study the heart, and when we study the heart, we got to take it out, we got to put it in some formaldehyde, and those things don't usually do well with survival. So those are things we see on autopsies. Oh, another question. Yeah.
Yes, first, thank you so much for helping us, and you're wonderful. And anyway, I would like to thank you first. But also, maybe I misunderstood you. You said that Eliquis, I think Eliquis can bring also a blood clot if you stay.
Oh, no, it prevents blood clots. So Eliquis will prevent it. So the patients that are in AFib will take a blood thinner like Eliquis to prevent clots. Yep.
But maybe I misunderstood. You said at one point the blood stayed.
Oh, right. So if you're not on a blood thinner,
If
if you're not on a blood thinner, the blood that sits there will clot. No, you're good. No, it's good to clarify because it can be kind of confusing. No, it's very important though that, you know, you are taking a blood thinner to prevent clotting, right? So when the blood sits in your heart during atrial fibrillation, because it's not being contracted, you need to be on a blood thinner. Otherwise it's going to clot. It's just the way it works. So, oh, you're welcome. No, good questions. Yeah. Well, another one back there. So good question. So aspirin is one of these things that I think most heart patients take. One of the things we know about preventing future heart disease is antiplatelet therapy. It's a big topic of conversation. It's something we study. And so a lot of the studies that look at preventing the progression of heart disease in general, whether that's valvular disease, coronary disease, says, hey, take an aspirin. It looks like it's good for you. So that's why. When you had your Watchman put in, the question was about why am I still taking an aspirin with Watchman? Well, it's not necessarily related to the Watchman device. It's related to everything else associated with heart disease. But this is a picture of the Watchman. This is what you have. This is the left atrial appendage. And so rather than occluding it from the outside, they come in and are able to block it from the inside. And so it's a nice option for patients who may have already had open heart surgery, or who don't want to undergo a surgery. This is a nice way to fix it. Yeah, one question here, and then I'll come back there. It could be how your cardiology wants to manage it. So the question is, hey, I'm on an anticoagulant and I was told not to take an aspirin with it. Yep, that's possible. That's not necessarily any bad advice. That's if their cardiology or your primary care doctor wants to manage it. Probably pretty appropriate. Go ahead.
It's not.
Yes. The question is, does this matter about position or anything like that? No, it doesn't. It's a good question though, because you kind of think about the heart flopping around, but it's actually pretty darn secure. You know, I think everybody watched the Bills game or at least saw what happened there. You know, how many billions of football tackles have happened before we've ever seen anybody talk about a heart problem, right? Tons, you know, billions. Concussions, a few per game, right? The brain, not well protected. The heart, very well protected. So that heart doesn't move around at all in there. It sits in a nice little sac with some fluid and it's well protected. So it doesn't move. The position there doesn't matter. Go ahead. That's a good question. I don't know. What made the heart stop on the market? I don't know. I mean, there's a lot of theories out there, but nobody's there. I think the biggest thing is just to rule out any other problem with him as to why it happened. And then you kind of go into these like one-offs of, you know, maybe he did have, you know, commotio cordis or something like that. I've never seen it before. I've seen people come in with fractured sternums and never seen it, but doesn't mean it doesn't happen. All right. So when we look at our data on these patients that have the Convergent trial, right? So what we're going to talk about is just, let's look at these patients that are very complex that we now treat together surgically and with ablations. And so we look at them, what we see is pretty good results. And so the study, we did it at like 27 centers. We had 150 some patients. We did some fancy stuff with randomizing you. Those are all things we don't need to dive into here, but I do like nice colorful graphs. And so this is it. So what this looks on the left is 12-month outcomes and 18-month outcomes. So we just break it down pretty simply. And so this first column over here, right? It's freedom from atrial fibrillation without being on any medications to control it. And so when we see the hybrid procedure versus just the endocardial ablation alone. So again, just doing the catheter ablation that we talked about alone, you know, that was, the freedom from AFib was only at 26%. When you combine it, when you take the best of both worlds with surgery and what cardiology offers together, we're at 52% here, freedom from AFib without any medications. And then you're looking over here, you got, what about freedom from AFib without changing your dose, right? Wow, now we're up to 65% of these patients that normally are in AFib, right? Very difficult to treat. Now you're at 65%. And then if you look up here and we say, oh, hey, what happens, you know, regardless, maybe we had to adjust your medications, maybe we had to increase your arrhythmia medications. 73% of you are out of AFib. Pretty darn good. And we said, well, this is probably just a fluke. It's probably going to go away by 18 months. And we look at it again. We say, yeah, there's a slight little regression here. We see a little bit, but almost 70% of patients are free from AFib. And these are people that have been in AFib indefinitely. I can tell you stories about people we've done who've been in AFib for 12 years, 25 years, and they're coming out and they're having much longer runs of sinus rhythm, if not indefinite sinus rhythm, you know, when we follow these patients out. And so, AFib is difficult to cure. Like I said, it requires multiple trips probably into getting ablation therapy and being followed up, but it is a disease that we are aggressively trying to understand more of and treat. Go ahead. Flutter. So does this work for flutter? So it's not approved for flutter, but portions of the flutter that I have treated people with flutter, and that's something that we would discuss with the cardiologist and maybe the electrophysiologist that's doing it. We've definitely treated probably 3 or 4 patients in the last 6 months that have flutter. We're able to treat a portion of the heart that can generate the flutter. And so I think it's very much worth a conversation about it. You know, flutter has a different mechanism to it, but it's all related to the atrium together. And so that's something we could discuss. And then we look at all these patients and we said, all right, let's say you're not free from AFib, but what if it's greater than 90% of the time you're in sinus rhythm? Well, if we look at that, about 73% of the people are free of AFib 90% of the time now at 18 months. That data is pretty incredible. If you look at it just with endocardial ablation, so just getting 1 ablation or 2 from the inside, it's about 36%. So we're doubling the effectiveness. And for those patients that have AFib who are symptomatic from it, they'll tell you it's very much worth being in sinus rhythm. But oh, what's the risk of death? Much less than 1% for those patients. So, yeah. And in the Convergent trial, nobody during the trial, nobody died from this. So there's no deaths from the trial data, but I won't tell you it will be 0 because there's always the one-offs of things that happen for other reasons. And so pretty much the summary of this is like when cardiology and surgeons work together, it benefits the patients. And so that's what we're doing here at Eisenhower. Go ahead. Yeah, one more question. Sure. So the question is, what about just putting a pacemaker in? Good question. That is an option for treating AFib. So you are generating a paced rhythm, and it's something we talked to the cardiologist about, but it is a way that we do treat AFib. Sometimes it's very difficult to treat AFib. Sometimes we'll knock out some of the electrical signal in the heart permanently and just take over control. And that is a viable therapy for treating AFib. Being in sinus rhythm is still better, but for patients that can't get there, it's not a bad option. Typically, no, it doesn't. Now, anytime you stimulate the heart, you can get different arrhythmias. So, but it shouldn't treat your AFib just putting it in. It'll treat the symptoms of it. It'll help control your heart rate. We'll be able to give you more medications. If we give you medications and your heart rate slows down, putting a pacemaker in would be how you would treat that. And sometimes to control your AFib, that's what we have to do. But it can get complex, the different treatment algorithms we go down. And so, you know, we take each patient, kind of look at the scenarios and treat them uniquely, you know, try not to put you in a certain box. We just try to say, all right, what's the issue here and how do we quickly treat it? And again, your symptoms are going to be better. That's what the slide shows, right? So the people that had it before, much improved, you know, all of their symptoms from palpitations to lightheadedness to exercise intolerance. And I think for most of us, we just want to be able to go outside, have a good day, exercise, maybe take some stairs, maybe park a little bit closer at the grocery store or park a little farther, not have to worry about it, and walk in and not be short of breath. Like there's just very simple things you want to do. And patients in AFib just can oftentimes struggle with that. So I'll just wrap it up, take questions and things, and I should probably just have a whole clinic right here. We can just have a clinic. We just have a clinic, but you know, ultimately, you know, we're combining approaches together. The convergent procedure has been very successful here. We've been doing it for about 18 months since I got here. Talk about getting your left atrial appendage managed. It's important for you that are in AFib, you know, to maybe come off of a blood thinner. Because personally, for me, I'm not a big fan of being on blood thinner for life. I'm a very active person. I do a lot of things outdoors, and those on blood thinners who are active will tell you stories about the times they cut themselves and continue to bleed. So I just think for me, personally, that's my decision. And so managing your appendage, which we have options for here, is something that you can discuss. And then, you know, I would say, all of you are local because you're here, but you know, Eisenhower, we're really growing. The Heart Institute's going to grow over the next 5 years significantly. We're putting a lot of effort, money, and personnel into expanding what we're offering here. And I'll tell you what we're offering here would rival what most large cities have, just in the ability to treat complex cases and the quality of the physicians here. So if this is something that you have, which I know a lot of you do, or you have loved ones or friends that know about it, just come in. I'll have some cards. We have Leon Feldman in his office over in cardiology is going to take a lot of these phone calls and begin kind of funneling this into our AFib program here. And so we're happy to kind of get you connected there. Yes. More questions. Go ahead. Whoever's up. Yeah. In the back right there, and then I'll come up front again. Yeah.
The video you showed about what the AFib looks like in the heart.
Yeah.
Is it the same situation for its relative supraventricular tachycardia?
It's different. So the question is the video I showed of the AFib, is it similar to SVT, which is supraventricular tachycardia? So no, it's a different, the process of that arrhythmia is different. However, some of the symptoms you may feel, which is a fast heart rate, would be that, but the mechanism of it can be very different. So got a question up here. Yep.
Yeah, I have 100% enlarged atria,
Yeah.
and the cardiologists, I've seen 4 of them, have said that they very rarely ever see that, if ever.
Sure.
I've had AFib in my 40s, which went away when I was a professional athlete, and has come back. They say the kind of pumps real hard in your heart. I don't know what that's called. But
Sure.
when I was in the 40s, and now recently I've just been diagnosed with the kind that you don't feel.
Sure. Yep.
But the combination of heart failure and well, I have heart failure and enlarged atria. Is there any options for me that you could recommend?
I think what I would recommend is that's why we have this program here, this AFib program now that we're growing, because there's one of you maybe here, maybe 2 or 3 of you, but if you look out, we have hundreds of patients just like you that we're addressing. I would say it's probably too complex for a public conversation, but I would be happy to bring you into the clinic whenever you want, and we'll just sit down and kind of look through your history. I think that's what I would do. There are options to treat it. It's not a dead end road. I will tell you this, and I don't know who's listening on there, but surgically, we didn't help AFib for a while because we published some data a while ago that said, whether you're in sinus rhythm or not doesn't matter. It just matters if your heart rate's controlled, meaning you don't have a fast heart rate. Well, I'll call BS on most of that data because I've seen many patients that have rate controlled AFib that still go into heart failure. And so as a surgical society, we had some studies that looked at that there was really no difference in short-term outcomes, but we didn't really look at patients long-term, like 15, 20 years. And so we're still reeling from some of that data that we published. And it wasn't necessarily wrong at the time. It's what we knew. But as we start to see this disease progressing further and we start to see more investment in the space of understanding how this disease works, we're able to address patients like you who have a complex long-term AFib with enlarged atrium. Yes, over there. Yeah.
Medications
to the surgeon?
Yeah, good question. So the question is, we can thank Apple for a lot of the new diagnosis of AFib. So that data that we published about the increase in population was before people started wearing Apple Watches. So it's a very nice way to see where you are. It's actually very helpful. The question was just around, how do we go about looking at other options for treating our AFib when our provider may or may not be treating it the same way. I would say, this is where contacting our organization to reach out, because really what it is, it's a I'm telling you, I'm going to use this term a lot, but medicine's becoming multidisciplinary. It's not a siloed space anymore. And so we would talk to your primary care physician, your cardiologist, and then probably an electrophysiologist who's a cardiologist that specializes in the electrical activity. And then you'd eventually involve a surgeon. But again, it's all about just having the understanding of what's going on first, making sure everybody's on the same page, and then picking the steps going forward. But there are plenty of options there. And oftentimes AFib can be, as we've studied it more, very complex. And so you do need a team with different areas of expertise. So coming to see a surgeon typically is not the first stop. It needs to be a cardiologist first, because they're going to manage a lot of the other things that go around AFib. Go ahead. Yeah, continue.
Bottom of the list, but he has it all.
Yeah. I get tired of reading them and like, yep, check the box. I'm like, just stop checking and just select all. So we have that option now when you come to clinic, just select all. She said her husband has every symptom we mentioned. And so again, I think the best thing to do is to reach out for a second opinion and to do it. And I think, like I said, there's a lot of mixed data out there where from the surgical side, we're guilty for some of that, putting it out there and saying a lot of the things that they're doing is controlling the rate. And maybe there's a rhythm thing, but coming in and trying to diagnose it today would be tough, but we have a team that can do that. And I'm going to keep moving around. There's a hand in the back that I've been trying to get to way back there, and then I'm going to come up here.
And then we have some on Zoom as well.
Oh, you got Zoom. Oh, the question is if you're 80 or older, can you have the procedure? Well, what I've appreciated about 80-year-olds moving out to the desert is that they're really, really healthy. So yes, 80-year-olds, I think age is, again, the old cliche, it's a number. It's really depending on how healthy you are. And so that's something we take into consideration. So I'll tell you that age is an issue when it comes to general anesthesia sometimes. It's a different recovery process when you're 80, regardless of how healthy you are. But it's a very safe procedure for that. We've done it numerous times on people in their 80s. Right up here, and then I go to the chat real quick. Yep. Sure. So the question was like, how does the team work? There's a lot of cardiologists out there that have different management styles. The question is like, how does the referral process happen? What's the pathways to getting a referral? And so I would say that is, if you're here at Eisenhower, that's something that the AFib team here would begin discussing. And if that's something that you want to do, that's something you mentioned to the cardiologist. And again, this is a changing paradigm. It's a sensitive subject when it comes to AFib because there are a lot of treatment options for it. Medicine works really well for some people, but there's a large population of it. Like I said, about 45% that stay in AFib. And so it's a paradigm shift. We're kind of in a gray space when it comes to treating AFib. I'll be completely honest with you. I tell that to all my patients. You're in this gray zone of a space where there's a lot more data coming out. I didn't even show you the data on dementia and AFib. It's crazy, the data that's coming out with a guy in Utah that's doing a lot of the research, but people that are AFib have a much higher rate of dementia, and it's probably due to microemboli strokes and things. And so that data is there. It's been published, but it hasn't been well recognized yet, but it's coming. And so as more of that data comes out, more people appreciate the AFib problem, we're going to refer you in, but we have a network that does this here, so we can get that referral over and get you seen. All right, to the chat, and then I'll keep answering here because I get distracted. Go ahead.
Did you want to see them or they're on the screen, whichever you prefer?
Just start at the top, scroll to the top, or
no, just back to where we were. There was just
here we go. Yep. With persistent AFib, is it better to treat with rate control versus rhythm control? And then that was Lisa. So Lisa asked, with persistent AFib, is it better to treat with rate control and rhythm control? I'll tell you, like I said, the data originally was there was no difference, but over the long term, I'm going to tell you that rhythm control is better for preventing the long-term symptoms of going into heart failure. If you haven't, please discuss further rate versus rhythm. Yeah, control options. Yep. So rate control is not necessarily a bad option. Sometimes it's a great option depending on where you are and the other symptoms that are going on and the other problems you personally have. But it's a conversation that you begin with your primary care and your cardiologist about it. And I think most of it's just being aware of options to treat it. And sometimes as a patient, I'll tell you that you've got to be the advocate, because sometimes physicians, we're not perfect. We don't know everything about it. We do our best to stay up to date, but it's something that you as a patient can say, hey, I'm interested in understanding. Am I a candidate for ablation? Is the rhythm therapy right? Can I go get a second opinion? You can always ask for a second opinion. That's your right. It's your care. It's your body. We're here to help you and provide you advice, but you don't have to accept it. You can say, hey, I'm going to go look around and find some other things. I think it's very important to empower the patients to do that, because it doesn't stop with the physician. It stops with you and what you are willing to accept. Is ablation helpful for episodic AFib? It might be, depending on how often. And yeah, so I would say, yeah, that's something you should address. Episodic AFib. Somebody asked, hey, if it's happened once or twice a week, should I look at getting ablation therapy? I would say yes. Once you go on Eliquis, do you have to take it forever? No, you never have to do anything forever. It's up to you. But if you are in AFib and you don't want to have a risk of a stroke, then I would say take Eliquis. But again, this is a conversation, because sometimes your risk of a stroke, if you don't have any other symptoms, and we have a couple of scores that we measure that the cardiologist and us, we use to discuss risks of patients that have AFib and their risk of stroke. It's called a CHADS-VASc score. We look at that to determine it. So no, it's all about balancing risks. You got to remember, everything is up to you guys. So our job is to present risks and benefits to you. We say, hey, if you don't take a blood thinner, you have a 5 times likelihood of having a stroke. You know, maybe it's at 3 or 4% a year. So do you want to take a risk of a stroke at 3 or 4% a year? Or do you want to take a blood thinner and have a small risk of bleeding? That's up to you, right? It's just balancing of the risks you're willing to accept. We don't have to make that decision for you. We just tell you what, to our best of our ability, what the data shows and what we expect to be the outcome if you choose path A or path B. So that's a conversation you have. Yeah, another question here. Yeah. No, baby aspirin is not considered a blood thinner. So not in the sense of what we're talking about here.
But supposedly it's, I've been taking.
Yeah.
that for years.
Yeah, it's going to treat your platelets, and in theory, that's going to help with some of the activity of the platelets. It's not considered a primary blood thinner in the sense of what we're talking about here for treating AFib.
One question on chat real quick, and we'll close that off. Is ablation safe at 80 years plus?
Yes, ablation is safe at 80 years plus. I think somebody back here asked it too. So it's good to go at 80 years plus. I would say, depending on you and the other risk factors, it is a safe procedure to have. Bill, you had a question here. Yeah, good. We got the chat. We have some more questions. Yeah, we'll just start here. We'll work our way back. For sure. I'll tell you, hey, Dr. Patel, if you're out there listening, your patient would like a Watchman device. No, it's something, yeah, it's a referral over to the electrophysiologist. So again, it's going to be you being an advocate to say, hey, where's that referral? Can I get that referral over there? And then he'll send you over to get it done. But I'll give you my card afterwards. You can just call my office, and that'll just remind me to shoot him a little text message after this, or we can take a selfie together after this and we'll just do it. See, millennial generation, we like selfies. Good question. So the question is, my wife has had an ablation, has AFib, has had an ablation, correct? And still having some episodic AFib, what to do? That's a very common thing. We just looked at the data, right? The data says like one ablation is probably not enough. It may reoccur. So if you don't have a cardiologist here, that's where we're going to start first. And so if you need help getting that, I can give you my card. She got an appointment already. Good. So that's going to start the process. So we're going to get you in there, and that's kind of like the funnel, right? We're going to funnel everybody in. They come into cardiology, and then we're going to funnel you into our AFib program. So give us some time to get you funneled in with the cardiologist there. But I would, again, be your advocate. Say, hey, I want some answers. I want to get some treatment here. Yes, in the back over there in the pink. Sure. Good question. So the question here is like, had AFib for a while, had a stroke, had been on Eliquis. Now I've noticed that my heart rate is starting to slow down at times in the evening when she's laying down. So what could be causing that? So again, it's like diagnosis on the spot. It's kind of like Dr. House here, but I would say, we need to, again, go back to the cardiologist and do some workup and see what's going on, either be able to record. We're able to record your electrical signals in your heart for different periods of time. Could be 7 days, could be 14 days, could be longer than that with some devices that we have. And the Apple Watch is great for identifying it, but sometimes we need a little more data to look at what's happening. But what happens again in that setting, you know, where your heart starts to go slow and it may go fast again and abnormally slow. It's around your sinus node. Remember, the sinus node is what's doing its thing, right? And so when your sinus node gets sick, sometimes people with AFib get a sick sinus node, meaning it gets the cold and doesn't work right, so it slows down. It's the easiest way to break it down. The EP cardiologist won't like what I said, but that's the truth. Like it gets sick, and so it has a problem keeping up sometimes. And so that may be what's happening. And so again, it's something we just need to be able to look at electrically and see what's happening. So yep, it could be. It definitely could be.
I don't have an Apple Watch, but this reminds me.
This gentleman doesn't have an Apple Watch. Somebody, Bill, are we putting out Apple Watch? We should have an Apple Watch ultimately. Okay.
Can you have AFib and be asymptomatic?
Some people have AFib and they never know it, right? But remember, there's a window where people have it, right? So sometimes people already have some heart failure, they're already short of breath and fatigue, and they're not that active. So when they go to AFib, they may never know. But there will be a point of time, if you live long enough with AFib, that you will begin to develop the symptoms. But again, we see patients all the time that just think they're aging and slowing down. Well, it turns out your heart's been sick over time, you know, like, oh, I didn't realize, like, it's the subtle things. Like I was just telling you, like, oh, I don't park. I drive around the grocery lot a couple times more to make sure I park closer because I don't like walking from the back, right? You don't realize you're doing it, but your body's like sub-selecting because you get more short of breath when you walk farther. And those are the subtle things that change that are very difficult to pick up until it's like, God, I can't get out of bed today. What's going on? Well, you went from like parking in the back of the lot of the grocery store to parking at the front, and now you can't get out of bed. But you don't realize it until you can't get out of bed that, damn, yeah, you're right. If I think about it, the last 2 years, I've been slowing down a lot. I thought I was getting old. Well, no, it turns out you had probably a heart problem.
We have 2 questions about that same drug up on the chat.
Oh, how long is it safe to take amiodarone? I don't know. Amiodarone is one of those drugs that works really, really well, but it has a side effect profile that can be pretty intense with some patients. And so the safety of that, I don't know. I don't know if there's data on that. If there is, I don't know it. It'd be something that the electrophysiologists who know more about those drugs than I do would probably tell you, or a pharmacist. But again, it's a balance of risks. What's the risk of continuing to take amiodarone versus going into AFib? If it's keeping you out of AFib, well, there may be some benefit there. Can you discuss the risk of amiodarone? Yeah, sure. So it can be anything from the subtlety of feeling nauseous and not being able to tolerate your diet to having lung issues, kidney issues. I mean, if anybody ever has read the back of a drug, you know, like, hey, I opened my packet and I started reading, you're like, oh my God, why am I taking this? It sounds awful. There's a long list of it. The ones for amiodarone can be a little more what we call cytotoxic, can be toxic to the cells. But again, it's a balance of risk. Is it better to stay in AFib, or is it better to take a medication that helps you control it? It's tough to know. Yeah. Well, so the question here is like, I had sleep apnea, had CPAP, came in, had the hybrid procedure done. Now it doesn't feel like he's having any issues with sleep apnea, needing the CPAP at night, not having those same symptoms. Again, sleep apnea is caused by, you know, we can dive into that, but there's a subset of reasons why sleep apnea happen. Just treating your heart may not fix that, but being more active during the day, not having the AFib episodes, maybe there's some benefit there long-term that actually treats some of the cause effects of why the sleep apnea is happening. But I would say, I would just want to confirm that you're not having sleep apnea. In order to do that, it usually typically requires a sleep test to just confirm it. But that's great that you're not feeling that. Oh my God, no questions? Wait, there's one more. Wait, this is great. All right. Any more questions? Awesome. Thank you guys. Sorry it ran long.